From anatomy to anesthesiology, from pathology to pharmacology, from microbiology to medicine, a one-man resource to the world of health sciences. Welcome to Dr. Paul's Medical Lectures. A practicing physician, Dr. Paul offers you essential insights on diseases afflicting millions of people around the world. For today's lecture, here is Dr. Paul.
Candidiasis is very common thing. In fact, all of us carry candidiasis, like candida, the organism candida in our body. So it's a opportunistic pathogen. Whenever our immunity falls down due to various risk factors, this organism multiply and cause disease. It enters into the bloodstream and cause the disease. So Candida albicans is everywhere, and it can be cultured from the mouth and vagina in women and feces of most people. I mean, a symptomatic condition. Now, cutaneous and oral lesions are very common. Now, let me talk a few minutes about risk factors. The risk factors for invasive candidiasis include neutropenia, whenever the neutrophil count goes down, or a recent surgery, or broad-spectrum antimicrobial therapy, or even advanced kidney disease, or sometimes intravascular catheters, especially when providing total parenteral nutrition. These catheters give an access to these organisms. And also, whenever there is cellular immunodeficiency, the mucocutaneous candidiasis is a highly probable condition. So when you see these risk factors, you should always be thinking of this organism. The other group is HIV. Patients with HIV, they have this cellular immunity diminished levels, and whenever they don't have this immunity reconstitution, they are more prone to this infection. So the organisms go in and they form microabscesses, later macro abscesses in major organs and cause the disease. So Candida, I mean, as far as it stays in the skin, no problem, but whenever it enters into the bloodstream, then the problem happens, and that happens most commonly whenever the blastospheres they convert to the next stage, like a pseudohyphae and hyphae. So that whenever the blastospheres they become the pseudohyphae and hyphae, they get that power to penetrate. But Candida glabrata can cause extensive infection, even though it does not transform into pseudohypha or hypha. So Candida albicans transform and enters the blood, whereas Candida glabrata, it does not have to transform in order to enter the bloodstream. So that's an important difference between the two. So remember the risk factors: antimicrobial agents, indwelling intravascular catheters like hyperalimentation, and also indwelling urinary catheters. And whenever parenteral glucocorticoids are given that suppress the immunity, when people are on respirators, when they have neutropenia, when they have abdominal or thoracic surgery, or even when they are on chemotherapy, or taking some immunosuppressive agents for organ transplantation, or people with severe burns, or even in neonates who born prematurely or with low dose, or sometimes people who use illicit drugs, especially intravascularly, like intravenous IV drug use. And as I said, HIV patients with low CD4 counts. So all these people are susceptible to mucocutaneous candidiasis. All of them run the risk, and especially when these organisms enter into the blood, they get these hematogenous serious infections. And also a few words about vaginal candidiasis in women. Most of the women, like almost 90% of the women, would have at least a single attack of vaginal candidiasis. Now, risk factors are the same. Women with diabetes, women with HIV, women with IV drug abuse, and all those things I said will also apply to vaginal, like vaginal candidiasis. Now, a few words about treatment. First, let's talk about mucosal candidiasis, especially when there is esophagus is involved, because that's the most frequent type of significant mucosal disease. So esophagitis and gastritis, and they cause the substernal odynophagia, the pain with the feeding, and also the gastro reflux disease, and also substernal pain. So oral candidiasis, it can cause that problem, esophagitis and gastritis, and you can do an endoscopy and do the biopsy and culture in order to establish the diagnosis. If patients are able to swallow and take adequate amounts, that's good. You can give them drugs and you can treat them with things like fluconazole or itraconazole. So if the patients can take something by mouth, use fluconazole and treat it, or itraconazole and treat it. But sometimes it goes further. Like patients can't even take anything by mouth, then you have to use intravenous like voriconazole, or intravenous amphotericin B, or intravenous capsofungin, or intravenous anidulafungin. These are all drugs that are available intravenously. So use oral when the patient can swallow, or if the patient cannot swallow, use intravenous medications. Now, how do you treat vulvovaginal candidiasis? As I said, it happens almost like 90% of women at least once during their lifetime. They have these risk factors like pregnancy, uncontrolled diabetes mellitus, and also broad spectrum antimicrobial treatment, and sometimes corticosteroid use, HIV infection. All of these conditions predispose women to vaginal candidiasis, and they present with burning vaginal discharge and sometimes even dyspareunia, difficulty having sex. And you have to use clotrimazole or meconazole. Those are the most important drugs. Clotrimazole or meconazole. Both are effective. And also fluconazole, 150 milligram dose of fluconazole. It also helps. Okay, I will take care of it. Yeah.
You want an X-ray?
Yeah. Thank you. Finally, I want to talk about candidal endocarditis. Many times, when the heart structures like valves are exposed, patients will develop candidal endocarditis. They may be having a surgery like a valvular heart surgery, or sometimes receiving parenteral administration of illicit drugs that takes the candidal organisms directly into their valves, sometimes intravascular hyperalimentation, sometimes prosthetic valves following surgery. So these patients develop candidal candidal carditis, like endocarditis, due to candidal organisms. And what you do is you culture. When you see these vegetations, the vegetations are cultured, and the treatment for a long time is amphotericin B. Amphotericin B used intravenously, and sometimes you have to do more extensive treatment, like removing those vegetations whenever they are extensively grown on valves. So amphotericin B is very, very useful for this candidal endocarditis. So you see, folks, let me recap the points. Mucosal candidiasis, when esophagus or anything in the gastrointestinal tract or mouth are involved, and then vaginal candidiasis, that's an important area where people present with this problem. And finally, candidal endocarditis, when the heart is involved by candida. So candida is everywhere, and the risk factors, they play the predominant role who is affected by this disease. As I said, the treatment involves topical agents like clotrimazole, or oral agents like clotrimazole, fluconazole, itraconazole, or intravenous treatment with agents like amphotericin, capsofungin H. Those things, I hope, helped you. Thank you very much for your patient listening. Visit our website at www.drpaul.org. Thank you.
Thanks for listening. For more medical videos, please visit us at www.drpaul.org and take time to browse through hundreds of health videos we regularly post on our site. If you are preparing for USMLE, PLAB, and other medical exams, make sure you visit our website to browse through our videos explaining the essential points you need to know before taking these examinations. For more information, visit us at www.drpaul.org. Thank you, and may God richly bless you.